So sorry about that, but we're just going to move along, and I'm just going to quickly introduce Dr. Asim Grover, who is going to be speaking to the optimization of substance use care in a rural setting. Dr. Asim Grover is a rural family physician, as well as a site medical director at the Fraser Canyon Hospital in Hope, which is situated at the most eastern edge of Fraser Health. Dr. Grover has special interests in addictions and overdose response and emergency preparedness. Asim was born and raised in the Fraser Valley East and completed his residency at the UBC St. Paul's Family Medicine Program in Vancouver. He has worked in Hope and the Fraser Canyon since 2016. Dr. Grover's passion is to bring equitable resources to the most vulnerable and underserviced areas. He firmly believes that an arbitrary geographical line should not determine the level of healthcare a patient may have access to. So welcome, Dr. Grover, and I'm going to pass it over to you. Do you want to share your slides, or do you want me to share them?
I would love to share on my side if possible.
Okay, perfect.
Okay, if that's okay with you.
Yes.
Thank you, Angie, for having me. And
thanks for joining.
We're here and go from here. All right, is that clear for everybody? Just kind of give me a thumbs up. Thank you, Angie, for the introduction, and thanks for the opportunity to speak to you guys today. I will try not to be too boring today, but I'm very certain that I have some exciting pictures and things to show you guys. Okay, so my name is Asim Grover. I am a family physician, and because of my residency experience being in St. Paul's Hospital in 2012 to 2014, I had the opportunity to be quite exposed to a lot of variety of cases of addictions related conditions. And so that sort of propelled me into being an addictions champion here in Hope, where I've been born and raised in the Fraser Valley East my entire life. And so working in this sort of rural community, I had the opportunity to kind of jump in with both feet and see what I could do. And then before you know it, I'm involved in all this stuff. So I recently took over the site medical director role about 1.5 years, 2 years ago. And the new doctors at BC-elect was the previous director. And so I had some great mentorship. So before we start, I'm honored to live, work on the traditional, ancestral, and unceded territory of the Coast Salish, Stolo, and Kapluk nations. And that's really involving sort of the Agassiz, Hope, and the Fraser Canyon regions. Disclosures, I've received an educational honorarium for diabetes medications just because I wanted to learn about them a little bit more, but nothing pertaining to the current stuff being presented today and nothing addictions related. And just for simplicity, I'll be using the term Suboxone when I do talk about buprenorphine and slow release oral morphine. All right, so geography. So I tried to sort of encompass most of the area or people that we may be talking to today, and I circled Hope there. So geography matters. We've learned that in the last, I would say, few years. Hope and Merritt, were the victims of pretty significant weather disaster events that led to some emergency management. And then this year we have California, and then obviously New Zealand, if you guys can keep up with the news. And so climate change really does matter. When you work in a rural community, I never actually considered how we got our medications, because at times we do rely on getting medications a few days at a time, or a particular dispensing program where they'll bring it up a week at a time, and sometimes in some communities a day at a time. And so that puts a lot of communities and rural communities, especially, in sort of a vulnerable position. And we really learned that once our road to hope was essentially looking like that. Now, this is my drive to hope from Abbotsford, which is about roughly 70 kilometers. But as you can see, that when Highway 1 is impacted, a lot of things get problematic. And there are disasters that happen all the times in rural communities, but when there's a disaster affecting food getting to Vancouver, and then it's a state of emergency for the province. So a little bit about Hope. We serve a population of roughly 6,000 to 8,000 people. When you include the catchment area of all the Indigenous communities and up to Manning Park, it is approximately about 88,000 people. And Hope, like other rural communities in BC, we have sort of Canada problems, more along the lines of geographical problems. So my portfolio in the area that I'm serving for addiction medicine will range from as east as, say, Manning Park, which is about roughly 67 kilometers away, and then as north as our Boston Bar Indigenous Reserve, which is about 77 kilometers north. So you can see that geographically there are some challenges, and every rural community will have different length in their sizes or spokes, but a lot of rural communities, for the most part, are either reliant on or are the hub of a hub and spoke model. And so Fraser Canyon Hospital, being at the sort of transport nexus of three of the four major highways, that's why the hospital was situated there. And so we essentially have a small 10-bed hospital with 2 hospice, 5 ER beds, 1 trauma bay, gynae, and fast track. And I started in Hope in roughly 2016, and there were no addiction services at that time, and it was solely reliant on a telehealth service that connected with Surrey. And at that time, in the pre-COVID era, telehealth services were really, really shoddy. Also, just to acknowledge that there are greater than 10 Indigenous communities that we do serve in the area, and there are 3 pharmacies which are about 20 feet away from each other in our hub of Hope. Again, this is kind of a snapshot of our hub. We also do have a long-term care lodge there as well, and a public health unit and a primary care service as well. So that's just kind of giving you some context. So now let's talk about sort of rural realities. And when I've gone to a lot of addiction talks, especially involving what kind of services or care we should be providing, we have to acknowledge that there is a rural reality. And when it comes to rural realities, I don't think that this is mentioned enough. And with regards to the geography being large, with our rural realities that we only have so many pharmacies, they're very limited in resources. We don't have an abundance of allied health resources, and when we do have allied health resources, they're only available certain days of the week or certain hours of the day. And so that's why care looks different when it's a day presentation versus night presentation. And unfortunately, our addictions populations, historically speaking, tend to access services at sort of non-banking hours, if I had to put it in certain words. But anyways, it may not align with when the services are essentially need to be available for our patients. Also, anyone working in sort of rural settings acknowledges that they have to wear many hats, whether it be social work, whether it be even lab or x-ray services, and especially physicians. We are really put in a position where we have to wear multiple hats. I know in certain settings that nurses will do lab draws, could do x-rays, and really could run the emergency department if needed to. And so these are just some things to consider, and that kind of poses challenges on how we do things as well. Now, this was highlighted just the other day. This was our 2022 report, and it really shows sort of the reason why we're talking today about this and the reason why it's so important. In 2021, we did have a significant, slightly increase in the number of overall deaths, but that does not mean that we are winning by any means. And so we are trying to be creative as a province, as a community, on how we sort of deliver care and how we have services running where we're not burning out our providers, our allied health, and our nurses. So I just want to take a moment to go through kind of an overview of addiction support here. And really, when we approach these situations, it has to be separated into acute care and community. And really, when the community transitions and the community care is strong, it really allows for acute care services to thrive. And what I mean by that is, if there's nowhere to go in the community, then everyone is going to be going to acute care. And when everyone's going to acute care, um, it unfortunately has to line up with timing, and it has to line up with numerous sort of availability of resources, which may not be the best for the patient. So going to community first, I think the most important thing for establishing any sort of addiction support in a community in a well-run manner, we need excellent clerical support. And with excellent clerical support, especially in a brick and mortar setting, ideally not within the same space as a family medicine office. And you can make it work within the family medicine office, but what I've learned over the years is it does pose challenges and other unique challenges. And so ideally in a different space, it can be nearby, but then it allows for a sort of a more specialized approach on how we're kind of dealing with patients that do come. When I initially started off the services, I started off with the Tuesdays and Wednesdays because it was best for my schedule. But what I realized is that after the weekend, it's always a bit of an undertaking to see what's happened over the course of the weekend, and therefore services for access should be allowed for Mondays, just because the pharmacies are not always open on the weekends, and that allows for various other issues to be troubleshooted on Mondays. So if you're providing any addiction services, whether you're available on Monday or not, you're going to have to do some addiction related services to troubleshoot what's happened over the weekend. And then not everyone makes their appointments, so I allow for a few 1 or 2 hours on Tuesdays just for any overflow. I'm not sure if anyone has noticed, but when it comes to Friday is a lot of procrastination, and especially when there's a long weekend coming up. That's why keeping a few hours for Fridays are very important, because it just allows for fine tuning and crossing off any T's and dotting any I's before the weekend, so it doesn't cause any issues for you over the weekend. There's a lot of funding models that are coming into place in different communities and in different health authorities. Within Fraser Health, we have iHeart and SUSAT, and really these are essentially programs to help with the housing, with the access to treatment and addictions care. So they will be available within the health authority. It's really about trying to find out how you can access them through your tertiary hubs, through your more suburban communities, because they should have responsibility in supporting your rural sites as well. And simple counseling and harm reduction can always provide excellent sort of care when it comes to fine tuning anything along the lines of teaching you how to use Narcan kits and so forth. I find that these can be delegated to anyone that has a significant interest in helping our most vulnerable people. It doesn't have to be a formal counselor per se with a significant degree, but really someone that's passionate about teaching harm reduction supply. And anyone that's providing addictions care, they have to have a strong relationship with the pharmacies, understanding the hours of operations, and if they have capacity for these sort of deliveries. This is probably the most important thing to understand, is because as rural providers, we wear many hats. And when we wear many hats as primary care providers, GPs, nurse practitioners, and even registered nurses in the community, we have to be able to allow for some flexibility, especially in a rural community. We don't have the urban care model where there's someone available or on call all the time. And this will really prevent burnout. So having that relationship, having that flexibility, allowing and educating the pharmacies on sort of missed dose protocols, as well as not just missed dose protocols, but emergency dose medications when needed. As a recent, the BC pharmacists are able to provide in a little bit more length in missed dose protocols. Are you guys able to see my mouse over here? Okay, perfect. So my involvement with acute care, as I do provide a lot of acute care services, overdose support by the phone. Sometimes there are individuals that are familiar faces that have had frequent overdoses. It's important to know who those people are, because really sometimes they could be in a downward spiral, and having more close follow-up with them it's very important. Or it doesn't have to be over the phone. It can be faxed to that sort of brick and mortar office that we had mentioned. Um, we have seen an uptick in overdoses with contaminated illicit supply. There are weird and wonderful mixtures out there, and so some of these patients, they do end up in critical care situations, and it's important for them to have some discussion with the provider, because uh, they may not fit the normal protocol of certain transportation of medications. Um, Historically, our site used to use, say, a fentanyl infusion, or even a midazolam or morphine infusion. Well, that's not ideal when we're dealing with people that use over 1,000 milligrams of morphine equivalents per day. And so that's something to acknowledge as well. And when patients come into buprenorphine, they're really transitioning from that pre-contemplative phase to that contemplative phase. And they're potentially, and maybe even a cry out for help. And this is very important that we use this opportunity to potentially look at inducing buprenorphine. Buprenorphine, in my opinion, is first line and second line in so many ways, because a lot of people don't necessarily uh, do it properly the first time. Sometimes they even access on the street, so they're reluctant. So a second try would be ideal. And it is most definitely one of the safest medications, especially with opioid agonist therapy. And then also, there's a reluctance for, right now, there's a lot of burnout with staff, especially in acute care, but the COW score really is some sort of it's just a slight, difference from the CWAL protocol in a lot of ways. If anything, it's actually less tedious. So those protocols can be taught very quickly with a PPO that we have here in some health authorities already, but can be printed right off the internet. And most importantly, involved in discharge planning. You never want to be in a situation where someone's discharged and they're on opioid agonist therapy, and then they get discharged to the community and don't have a dose they're waiting from at the pharmacy. Oh, sorry about that, guys. All right, some challenges. So I think that there are some challenges that I wanted to obviously just touch base on, and it's something that we deal with regularly, but we don't talk about it enough as well. And really, writing a duplicate pad prescription is a huge barrier to a lot of care sometimes. It's different when you're in an urban setting and you're in a fully supported sort of network where everything is a well-oiled machine. But when you're in a rural setting, you have a personal life, you're doing your family practice, you're working in the ER, you're doing a lot of things. And so you can really quickly identify what the patient needs. But a barrier to care, and which is amplified more so in rural communities, is a duplicate pad prescription. And I'm hoping one day that this can be reviewed and we can work on making that a little bit more simpler. And then that, we can provide some catch-up prescriptions if needed, but then again, that's still more work. A lot of our patients, they do present with unreliable timings, unreliable presentations. The illicit supply makes it very challenging sometimes to know what's happening exactly. And then also, if they've missed a couple doses, based on the College of Pharmacists recommendations and the College of Physicians, their prescription gets canceled midweek. And so as rural providers, we can't do this 7 days a week. And so that becomes challenging because it puts us in a tough situation where we have to build capacity for these sort of midweek prescription refills or re-prescribing the medication. There are strict prescribing rules that are not mandated by the physician necessarily, but the physicians and nurse practitioners have to abide by certain rules. And that means agreements and contracts be signed. And a lot of times, these are challenging patients, and we are in uncomfortable situations dealing with a lot of problems. We have these are vulnerable patients that have a history of severe post-traumatic stress, severe mental health, as well as history of domestic violence, sexual violence, and so forth. And it's not necessarily a quick visit. And these are very complex patients where at times a lot of the resources to support these patients for their other non-addiction related issues are not quickly accessible. And so we just have to acknowledge that those are realities. And so just to make sure that we acknowledge that they actually exist. And that's why some of the supports and counseling and various services need to be there to really help the primary care providers actually be able to do these sort of tasks efficiently. Education, academics, and this is a very quickly evolving field. I remember one person from the US came to a talk and said that Canada with addiction medicine is like the Wild West, because in the US they have federal rules regarding methadone prescribing, and then they have state to state rules that are very different. And so things are constantly changing. We're at one moment we're doing it a certain way, and then the next year it's done totally different. So examples of that: sublingual injections. Examples of that are microdosing at very, very small doses. An example of that, providing safe supply hydromorphone and varies with different prescribers. List of supply. Every week we have a drug checking group that comes to our town. We run what's in the illicit supply, and it gives us some idea of what's out there. It's amazing to see the concentration of fentanyls with every different week to week, as well as the concentrations of different contaminations. And I think for every community, I think they should have access to this because this is very important. And I'm happy to kind of share that afterwards or by email to Angie, who can spread it to everyone else. Despite knowing the best options, selling with less than ideal management due to HR and lack of resources. So I had talked about this earlier, and even though we acknowledge that some patients may need treatment and recovery and certain programs, the access to it, the getting transportation to that site, the timing, or their arbitrary rules that they have in place. For instance, they may want someone not on Suboxone or not on methadone or not on Cadian. Everyone has their different rules, and that makes it very, very challenging. Sorry about that. All right, so key learning. I got a bit of a dry throat, so I'm gonna take a moment here to pause for a second. Does anyone have any questions for a moment?
What's the makeup of your clinic? Who do you work with, I guess?
Yeah, so our makeup of our clinic is myself, the addictions provider. We'll have a harm reduction counselor. She works with our outreach team. She comes there for the mornings. And she also has the ability to refer to treatment. So she's a referring agent to treatment centers, so we get that ball rolling. And also we have intermittently, we have people dropping in depending on some needs. So potentially a social worker may come in on a certain day of the month based on us lining up some social work needs. We have something called iHeart, which is involved in housing. And so they do come and stop in for a few hours to see if anyone needs help with housing. And then also for our complex patients, we involve another program called SUSAT. And SUSAT will come in to help get them involved in sort of tertiary care treatment programs that are far outside of HOPE. And that can be done virtually, that can be done in person. It's totally dependent on what the need is and who the person is. But we have a computer for virtual services, which is a simple computer, and they can make the calls through Microsoft Teams based on our platform there. And that took about 4 or 5 years to establish all that, and that wasn't done overnight. I'll tell you that for sure. Okay, so key learning points. Sorry about that, guys. Pharmacy, I can't stress this enough. So having educating this pharmacist on missed dose protocols, these are all available online. And then you can also look at the BC Center of Substance Use, which will have some templates there, and they can be shared with the pharmacies, just so they're aware. Physicians, protect physicians and the nurse practitioners, as well as even nurses that are involved in this care. Have acknowledging with the pharmacy that there's a low barrier for emergency doses, and if there's a complex situation, then they can vet out when or when not to call you, and that really comes with time and relationships. Initially, you may get more calls, but then as you guys get better at this can improve over time. Reaffirming that ER is not the place to go, and if we start giving a dose in the emergency department, it starts conditioning them to come to the emergency department at times, especially if they miss the time in the pharmacy. Also, in BC, when a prescription is given at the pharmacy, it's on PharmaNet, but when it's given in the emergency department, it's not on PharmaNet. And so we have had certain circumstances where patients have been trying to double dose. So reaffirming that we can probably give maybe some short-acting medication to tie them to the morning, but not your long-acting medications like methadone, Kadian, and so forth. And so that's just making sure that's the case. And then if a long-acting dose is provided due to the unusual circumstance, it should be faxed to the pharmacy so they're aware, so then that dose can be discarded for safety. Catch up duplicate prescriptions, and this is really just to appease the colleges. Even though we are doing the right thing, we cannot always be there and get that dose on time. And the patients that are there at the pharmacy, they're only there for a certain amount of time, so it puts us in a bit of a crunch. And so making sure that the pharmacist has provided the physician all the details, and then making an appropriate decision, but not necessarily just waiting on that duplicate to arrive before giving that dose. That would be an unsuccessful model. And acknowledging that mistakes happen and learn from them. This is very important. We can't be too hard on ourselves. We have to grow from our mistakes. And acknowledging also that, greater than 95% of our 95% of the overdoses are not medication prescriber related. I believe there was a number that was thrown out just recently, because it's always changing. I believe 97% was stated to be sort of related to illicit supply. And so I know that even though that we are prescribing some medication, that overdoses can happen, but not to be hard on ourselves, because we are trying our best we can with the information we have. And it's a moving target, and this is a beast of an undertaking as well. So what I also realized, and when I was working in an urban setting early on in my career, a lot of people would receive the dose before coming in to see how drowsy it would make them, how the medication would affect them. Now, I think this is important to understand as well, to do intermittently. But what I found was when we're not open every day for sort of the addiction services, a lot of times the patients won't show up on that day if they have a dose available at the pharmacy. And yes, we can provide the training constantly, but I was finding that a lot of patients weren't. So the people that would continuously forget, I do have their dose and the day before, because then the pharmacy will cue them to come to our clinic when it's open. And I found that to be really successful. Now, if you are concerned about sort of the dose being higher, I do strongly recommend that they receive the dose, and then based on the peak effect, so with methadone 3 to 4 hours or Kadian 5 to 6 hours, that you do assess them to see how it makes them feel. And I can't stress that enough, because that would be sort of a more standard approach. And if you're open 7 days a week, then for sure do it that way. Retention. I think it's very important that when we look at retention of our patients, because sometimes with rural communities, you're the only show in town, and so proceeding with trauma-informed lens, to your best of your ability, right? I know it's easier said than done, but we have to acknowledge that, a lot of people struggle, and we have to acknowledge that they've gone through a lot, and so that approach is very important. Um, uh, Essentially, availability of a specialist MOA designated just for essentially addictions is so important. There will be various funding models and grants, and this is so important because the physician can't be there all the time. But within that brick and mortar space, having a specialist MOA available there during those regular working hours to help field those calls, vet those calls, connect with the pharmacies, and do a lot of the clerical work that supports the undertaking of the addictions work is a huge benefit, and that's what will keep any rural addictions team alive. And then they can also help navigate some of the other sort of allied health services as well. And ensuring that we have capacity for follow-up from acute care, whether it be the emergency department, whether it be inpatient care. And those are very, very important. And so also rural communities, because the primary care providers wear many hats. The opportunity to provide primary care services, and that can go a significant way with our clientele. And that's how you develop retention. Our vulnerable patients don't have the option to make 3-4 stops for their issues. And, a one-stop hub is absolutely the way to go. If there's opportunity to provide maybe bring in a GP or a NP to provide some specialized services. For instance, I'm a young male provider and I don't do PAPs and women's health exams on our addictions population because a lot of them have had sexual assault, various violence, and there's a lot of things that we have to acknowledge that are reality. And so I have a excellent NP that will come once a month, and she'll do the PAPs, she'll do the women's health stuff, and she's much better than I am at it. But bringing in those services within your colleague, your network that you have there, can make a huge, huge benefit to the community, and that provides the retention. This one-stop shop where you're providing as much as care as you possibly can, and then also community services, allowing them to bring in potentially food services, any sort of donational stuff that's happening there. Very, very important. And I know, like at hospitals and various non-addiction clinics, there's a Christmas festivity, there's Halloween, Easter. Allow that human experience to come into that clinic as well, because it will just allow for a better retention. Consistency, access. When it comes to access, the brick and mortar clinic outside the family practice with the specialist MOA who's able to take the calls, consistency, pharmacies, all those stuff are important. And then potentially when plan A, B, and C fail, they can access the emergency department, but with a plan to actually provide the communication that's what's been done there in the emergency. Providers, ideally more than one provider. If you have 2 providers, it's going to be easily maintained in a rural community and easily up to a population of 25,000 people. And so sharing the load, sharing that, and then getting support from essentially education, any particular grants, getting support from your colleagues, because pushing off these patients to just the addictions providers to sort out everything can be overwhelming. And so having some shared collective role, the entire network of colleagues don't need to necessarily do the addictions work, but again, they can do other things. Especially if they come into the emergency department, they can maybe do a lab work draw to look at their immune status, Hep C, HIV. They can do some x-rays, they can look at some primary care measures, but they can help out in other ways that make a big difference. And I think this comes to the last key learning point: everyone on board. When you're doing this undertaking of addiction, you need everyone on board to understand that they need to play a part in this too. They don't need to do the addictions work per se, but they need to help out in doing other things. And so, just like I alluded to earlier with the HIV, Hep C immune testing, understanding that having a relationship with their social workers, so when they do come in to the hospital or other allied health, that they are given the resources, understanding what the community services are. So for instance, we have the integrated housing team and outreach workers. And so the social worker should know who they are so they can then connect and do that work for you. Acknowledging that you are doing the addictions work as a champion to your medical director, to your medical staff there at the hospital, so they're aware. Because when you have complex patients, sometimes you need some of that additional inpatient support. It's just too hard to actually manage them in the community sometimes for more complex patients, especially when you have concurrent severe alcohol use disorder with concurrent severe opioid use disorder. And then also at your tertiary sites, introduce yourself that you are doing that sort of addiction services in that rural community. It's very, very important. And then also connect with the BC Center of Substance Use to let them know as well, and they can then ask them on ways that they can support your journey. A roadmap. I'm not sure if a lot of communities already have done this, but a roadmap can be very simple. It can be very complex. But acknowledging that with roadmaps, they're just a tool that your patients, your colleagues even, and as well as not your colleagues, but other services that are maybe beginning to learn what you have, can look at where they can access certain services. Also, by building the roadmap, it actually makes you think outside the box about maybe are there other parallel services that are doing something similar. We learned that First Nations Health Authority has been doing a lot of good things, and then really partnering with them so we're not duplicating efforts, so that we can apply for different sort of grants and different sort of models of care to support each other. Now, this is the realistic discussion, and I'm almost done, guys, so bear with me. But to really institute all this, it does take a considerable amount of time to initiate all this. And if there's a champion, they should be remunerated. They should be compensated well for the time. Because this is not an easy task to set up, but if anything, this is a sort of a model of care that needs to exist in most communities. And it's important that we look at overdoses, the morbidity, the mortality, for education and growth as well, because some of these patients, if we address their needs a bit earlier, they're not as big as a burden on the healthcare system, and they're not as big a burden on the acute care system, and which will only lead to issues later on. The smaller the community, the more you'll have a networking ability to have meetings with the MLA or the mayor, because really you'll need some components of extreme weather shelters, regular shelters around the year, and as well consideration for low barrier housing. And those are very important because that makes the transition from acute care that much more effortless. And then really the outreach team being the spoke of the hub. And so every community has stronger outreach teams, and then also connecting with your First Nations Health Authority just to avoid duplication. So I've thrown a lot of information at everyone here, and sorry to do that, but if we want to simplify everything, think about three sort of circles here: community, acute, and tertiary. And why I put the tertiary there is because this is about sort of rural medicine and the remote work that we're doing in a smaller community. But there are patients that require tertiary care services. So just because you live in a rural community doesn't mean that they should not have access to tertiary care services. We should be leaning on our acute care service to eventually get them to the tertiary care service, because it would be, even though you can try to manage them in the community, but we all have a certain amount of patients in our communities that are very challenging. They've failed a lot of community measures. They've even failed acute inpatient measures, but they keep coming back, and their overall morbidity and conditions are just worsening. And so acknowledging that some patients may need tertiary care services, that is okay to acknowledge, and that's why those relationships are important to have. So if you only remember 4 things: pharmacy, hours, operations, stat holiday closures are the bane of my existence, because without the education to your pharmacists, they don't get the doses, and that's a chaos for the ER. So after our plan, in place, and just making sure that they're aware of that too. Investing in MOA, who's also wanting to make changes in the community. Ongoing education and relationship with specialists to lean on for advice and support. Education is super important. We have excellent programs in the province to enhance education. One being the CSAM, and this year Victoria, and then also our Western Canada Addictions Forum in Kelowna, which is in May. And then team engagement hubs weekly. I think this is the most important thing that we've implemented in the recent few months. Establishing kind of who's declining, who's not doing very well, and highlighting if there's anything we can do for them as well. Really, what they need is a little bit more hand-holding during that week or during those few weeks, but acknowledging that the outreach workers letting you know that there are certain people that are declining significantly or have relapsed and are in a downward spiral. So trying to get to them before something bad really happens. And then our shelters, our extreme weather shelters, and our low barrier housing, we consider them hot zones or hot overdose zones potentially. And so acknowledging that those are some of the areas. There was one line that really resonated with me, and to be honest, I actually can't remember exactly where I heard this, but it's been echoed numerous times. I believe it was at a conference in Kelowna in 2017. But one individual said that it's easier to get high than get access to and get help. So just something to consider, acknowledging that even though we are trying to improve access to certain addiction treatment and services, it's an uphill challenge because the drug dealers and everyone that's involved in getting the supply out there, they're working harder than we are at times when it comes to this stuff, and it poses a huge challenge. And so we have to reduce the bureaucracy, and we have to actually try to match the level of access the drug dealers have to our patients, and then I think that it can make a massive change in the community.